apply to a condition in which a patient presents to a healthcare provider with an established conviction that they are infected with an antibiotic parasite. Boom. So if you show up to report one, you're delusional parasitosis. All right. Clinical presentation. Primary delusional parasitosis is diagnosed when no underlying medical conditions typically associated with disordered thinking are present. Disordered thinking. Already they're making it psychological. Affected people frequently were previously successful in their professions, relationships, and other activities. All right, so the people that were affected with delusional parasitosis were people of everyday standards, professionals, successful in their relationships and businesses and activities. All right. In the absence of a prior history of a mental health disorder, delusional parasitosis is considered only after multiple visits for care symptoms, itching, skin sensations. Okay, it says after multiple visits for cares. Okay, that means they're not supposed to diagnose you with delusional parasitosis the first time you show up. You have to show up multiple times. I got diagnosed the first time, just like 14,000 other families out here in the United States have been diagnosed with it the very first time they showed up, and repeatedly because they showed up convinced that they have an arthropod or a parasite. That right there makes them delusional parasitosis immediately. Okay, now, so the symptoms, itching and skin sensations are most common and lead to a preponderance of literature from the dermatological field. Clinical manifestations also can be neurologic, brain fog, fatigue, pain, weakness. All of those symptoms, the itching skin, the sensations, the brain fog, the fatigue, and the pain and weakness, and gastrointestinal, like constipation, diarrhea, or sensation movements in the gut, all are part of the Morgellons disease symptoms. Every one of them. Okay. Auditory or visual. Morgellons syndrome is a specific variant which sufferers see fibers emerging from the skin. That is the extra element, key element there for Morgellons. But the rest of those fit Morgellons. You see how they brought up Morgellons disease in the description of delusional parasitosis? Secondary delusional parasitosis occurs in association with identifiable health conditions. Identifiable. Alcoholism, bipolar disease, severe depression, drug abuse, schizophrenia, syphilis, thyroid disorders, vitamin deficiencies. Okay? In such cases, treatment of the underlying condition might resolve the fixation on parasite infestation. So as soon as you show up, they automatically got it that you have a fixation of it. They automatically can't discredit you when you show up. Unique to delusional parasitosis is the conviction that the illness is due to a parasite and the frequent auditory or visual identification of it. Patients often can describe or draw the organism or define activity and intent, submitting multiple specimens collected from clothing, articles, skin, stool, toilets, and around the house. Reported parasites. In many cases, family members or friends are drawn into the delusion, and a full deuce in a more disturbing scenario, a parent might project the delusion onto a child, resulting in potentially harmful attempts to cure the illness. Potentially harmful attempts. People suffering from delusional parasitosis can present without objective physical manifestations or, in the classic dermatologic case, with few to extensive skin lesions attributed to the parasite. Patients might have tried multiple home therapies, including potentially toxic applications or injections. Okay, it says patients might have tried, not been known to have tried, not did try. Okay. Pouring promethazine in the ears to quell the buzzing of the insects, as reported by one of my patients. That was an example. Patients often are prescribed empiric treatments for parasitic and arthropod infections by well-meaning practitioners. These treatments are rarely successful. Rarely. That means they have been successful at times. But they are often reported to have provided temporary symptomatic relief, a placebo effect, reinforcing the patient's erroneous belief that they are infected with a parasite. So automatically they're making you erroneous belief right there. It says automatically do not believe nothing you got to say as soon as you report it. You're automatically delusional, and this is doing nothing but confirming it all the way down to these doctors. Often the next step is referral to a specialist with the hope on the part of the referring provider they will know something I don't. The patient will believe Dr. X, or Dr. X will assume care of the patient. Eventually, depending on the patient's description of symptoms and the number of practitioners seen, a patient with DP will have undergone multiple examinations of specimens, biopsies, or skin or other body parts, colonoscopies, imaging, and laboratory evaluations, none of which reveals a reasonable parasitic cause for their symptoms, and which are usually all normal. Usually all normal. Mine were positive, but they removed it from the records. And the number of practitioners seen. I've seen many. Over a year, I got one stool sample test, and it took a year. Mental health evaluations. Suggestions to consider alternative diagnosis are rarely accepted, in particular recommendations that the patient try psychiatric medications, even just for symptom relief, are frequently met with anger and rejected out of hand. Both patient and practitioner become frustrated. The patients feel they are being told it's all in your head, and the practitioner is exhausted from the attempt to be compassionate and medically appropriate while faced with an often angry and occasionally insulting patient. Because we don't like to be gaslighted. They're not being compassionate. You're instructing them to gaslight the fuck out of us. We're not even allowed to claim that we have a parasite or anything because you automatically telling them we're delusional. Therapy for delusional parasites have relied on the use of antipsychotics. Some of this I'm going to skip because if you want, you can pause the video and read it right there. But it's a 10-minute limit on this thing. So I'll scroll it slow for you. All right. Whichever provider accepts a patient with potential delusional parasitosis, a long-term relationship should be expected. More rarity, etc., have suggested a thoughtful, phased, multi-visit approach in which the healthcare provider takes the patient through the stages of considerate but strategic history-taking managed expectations, appropriate diagnostic approach, and eventual introduction and maintenance of antipsychotic therapy. Low doses of medication are usually effective in improving or resolving the symptoms, but maintenance should continue for months, and relapse is common because they're not crazy. Treating patients with delusional parasitosis can be exhausting and frustrating, as it's easy for practitioners to dismiss these patients as out of their scope of expertise and disruptive to their usual practice. If a relationship, because they don't usually practice telling people they're delusional when they're not. All right, here we go. Management suggestions for healthcare providers. This is an important part. Creating a workup. Allow the patient to tell their story, but set limits on expectations for each visit. So they limit the patient each visit. Assure patients they are not alone in having these kind of problems. We have seen this before and have been able to help. Neither agree nor argue with patients about the delusion itself, automatically considered delusional, but affirm the severity and significance of the symptoms they describe. So you neither agree nor argue with them, but affirm the severity and significance of the symptoms they describe. Conduct an appropriate workup. Do not be distracted by the patient's interpretation of cause. Don't pay no attention to how this shit happened. Pay attention to the history and consider alternative conditions that can cause similar symptoms. Similar symptoms, not alike, not identical, not the same. Review records including all medications, both prescribed and over the counter. Obtain basic laboratory studies and thyroid function and sedimentation rate. Consider hepatitis and HIV testing, syphilis, serology, toxicology, and vitamin deficiencies. Since specimens brought in for formal analysis, allow the patient to choose the best examples. Not samples, examples. Management. Reassure patient about the results of basic laboratory tests. Reassure them. The labs we have done indicate that your bone marrow, kidneys, liver, thyroid, etc. are all healthy and working properly. Okay, but that's not what you're supposed to be checking for. That's what CDC is instructing you to test for. But a patient with delusional parasitosis needs you to test for the parasite. That way they can know that they're crazy or not. As clinical reports return indicating no parasites found in specimens and no underlying pathologies, introduce the idea of symptom control as a strategy. That's because none of those tests will show a parasite. It'll only show the diseases caused by them. We know it is safe to focus on symptoms even if we haven't found the cause. Look, they know it is safe to focus on symptoms even if we haven't found the cause. Don't make a distinction between mental and physical health. Instead, discuss the growing understanding of the mind-body connection and how we are just learning about how neurologic signaling affects our bodily well-being. Gaslight. Explain the use of antipsychotic drugs in terms of addressing the mind-body connection. You don't have schizophrenia. Gaslight. But this medication has helped people who have the same kind of problem. We don't yet fully understand how or why it works. Gaslight. As much as possible, recruit the patient's family. What happened to confidentiality? And friends, what happened to confidentiality? To help the patient normalize what might have been a severely disrupted life. Severely disrupted because you're telling people they're delusional when they're not will make them delusional. Perspectives, chapters, supplemental, blah, blah, blah. So you see what they're instructing these folks to do.